Good morning. Thank you for giving me the opportunity to speak today. My name is Matthew Connell. I'm a third-year medical student from Queen's University in Kingston, Ontario, and today I'll be presenting the results of our meta-analysis looking into the incidence of incisional hernias following single incision and traditional laparoscopic surgery. Before we begin, I have no conflicts of interest to declare. Single incision laparoscopic surgery was first introduced in the 1990s as a novel method of performing laparoscopic cholecystectomy. The early studies around this procedure focused on the perioperative outcomes, and these studies showed that single incision cholecystectomy was a safe and feasible alternative to the traditional laparoscopic approach, with comparable rates of bile duct injuries and postoperative complications. Since this time, the SILS technique has been applied to a variety of different intra-abdominal procedures. Previously published meta-analyses involving single incision laparoscopic cholecystectomy and appendectomy have shown that SILS is associated with improved cosmetic outcomes and reduced postoperative pain, although the clinical significance of these results is debated. These studies have also shown that SILS is associated with longer operative times as well as higher operative room costs. Interestingly, a study recently published in 2018 by Rizzo and colleagues has shown that single incision cholecystectomy may be associated with higher rates of minor and major adverse outcomes, contradicting previous research. As studies have begun to focus on the long-term outcomes following SILS, concern has been raised regarding a higher rate of incisional hernias following this procedure. In our study, we set out to determine whether single incisional laparoscopic surgery is associated with a higher rate of incisional hernias relative to the traditional laparoscopic approach. To answer this question, we conducted a meta-analysis in accordance with the PRISMA guidelines. The risk of bias in our included studies was assessed as outlined in the Cochrane Handbook, and the quality of evidence was assessed using the GRADE framework. All data analysis presented in this review was done using RevMan. The primary outcome for our study was the incidence of incisional hernias, and our secondary outcome was the incidence of incisional hernias requiring surgical repair. The inclusion criteria for studies to be included in this review were that studies be randomized controlled trials comparing a single incision laparoscopic procedure to its traditional laparoscopic counterpart, and that the rate of herniation be reported over a follow-up period lasting at least 6 months. Subgroup analyses were performed based on both the type of procedure performed as well as how follow-up was conducted. Our literature search, designed in consultation with medical librarian, found 309 articles. All abstracts were reviewed independently and in duplicate, leaving 29 articles for full text review. 4 of these studies were excluded for presenting data published in future studies, also included, and a further 3 were excluded for not meeting the inclusion criteria upon full review. In the end, 22 randomized controlled trials involving 3,340 patients were included in this analysis. The size of the included studies ranged from 40 to 600 patients, with publication dates spanning 2012 to 2017. Of the 22 studies, these covered 6 different single-incision laparoscopic procedures. 14 of these 22 studies involved single-incision laparoscopic cholecystectomy, and these accounted for just over 75% of the total patients enrolled in the trials. Of the 22 studies, 15 used commercially available SILS ports, while the remaining 7 used surgeon-fashioned devices. In all studies, the surgeons involved had previous experience in performing single-incision surgery. The follow-up period in the included studies ranged from 6 months to 48 months, with an average weighted follow-up time of 13 months. However, only 9 studies used routine clinical follow-up, which was defined as a scheduled in-office visit or a scheduled imaging appointment to assess for hernia development. In the 4 studies, a questionnaire-based method of follow-up was used, in which patients were sent questionnaires, and those deemed at high risk were brought in for further assessment. And in the remaining 9 studies, it was not specifically reported how incisional hernias were tracked over the follow-up period. Here we can see an outline of the risk of bias assigned to the included studies. Of note, blinding of participants as well as outcome assessors was not possible given the nature of the intervention and outcome in these studies. While we felt this was unlikely to influence the results, all studies were assigned an unclear risk of bias for these 2 categories. In the other bias category, a high risk of bias was assigned to studies which used a questionnaire-based method of follow-up, as well as to studies which used a variety of different SILS techniques within the SILS arm of their study. In the same category, an unclear risk of bias was assigned to those studies which did not report how follow-up was conducted, as well as to studies which were lacking information on the baseline characteristics which were known hernia risk factors, such as age, gender, and BMI. Moving on to the results, we found that single-incision laparoscopic surgery is associated with a higher rate of incisional hernias. 1.7% of patients in the SILS arm developed an incisional hernia, compared to 0.4% of patients in the traditional laparoscopic arm. This result was statistically significant and translated to an odds ratio of 2.83, with a 95% confidence interval spanning 1.34 to 5.98. For a 2 subgroup analysis, These were based on procedure type, which compared single incision cholecystectomy to all other single incision procedures, as well as method of follow-up, which compared studies using clinical follow-up to those using questionnaire to those which weren't reported. For both of these analyses, there was no subgroup effect that was noted. Here we can see that just over 75% of the patients underwent single incision cholecystectomy, leaving about the other 25 undergoing all other SILS procedures. It's also of note that in this other category, the event rate was quite low. In the SILS arm, there were only 4 hernias recorded, and in the traditional arm in this other group, there were actually none. And so with this low event rate in mind, while there was no subgroup effect noted, we do believe this poses some limitations to the generalizability of the results. For a secondary outcome of incisional hernias requiring surgical repair, there was no difference between single incision and traditional laparoscopic surgery. 0.9% of patients in the SILS arm underwent a second surgery to repair an incisional hernia, compared to 0.1% of patients in the traditional arm. However, these results are not statistically significant. To briefly summarize, this review has shown that single incision laparoscopic surgery is associated with a nearly 3-fold increased risk of developing an incisional hernia. However, the majority of this data is based on studies using single incision laparoscopic cholecystectomy, and further research is likely needed to fully characterize the risk of incisional hernias following other SILS procedures. Here we have an overview of the grade quality of evidence. The quality of evidence started as high, but was downgraded to moderate due to risk of bias. This was done as many of the studies which contributed most to the effect size had one or multiple categories of bias which had been assigned an unclear or high risk of bias. To conclude, this meta-analysis of 22 randomized controlled trials involving 3,340 patients has shown that single incision laparoscopic surgery is associated with an increased odds of developing an incisional hernia. Thank you for listening. At this point, I'd be glad to take any questions.